right, I think we can go ahead and get started. Welcome everyone to Geriatric Medicine Grand Rounds. I know there'll be a few more people trickling in, but we'll go ahead and get started. Thanks all for joining us. We have a really great speaker today who I'll introduce in a moment. I wanted to take a moment to thank our Grand Rounds committee. There are a whole group of folks who come together to put together the Grand Rounds for the year, and I want to thank all of them, and I will send out a list to all of you soon. We'll maybe add that to the next Grand Rounds invite. All right, so thank you so much for joining us, Dr. Panch, today. Dr. Panch is an associate professor of medicine in the Division of Hematology. She also has extensive expertise, research experience, lots of publications, and lots of funding in her area of expertise of transfusion medicine, and practices clinically both outpatient and in inpatient settings, and does a lot of education as well. We really appreciate you taking time out of your very busy schedule to share your expertise with us. I know I was just mentioning to Dr. Panch that a lot of us send e-consults to hematology from the senior care clinic and probably from the post-acute care services. So we really appreciate you taking the time to talk us through all of this.
Thank you. Thanks for the opportunity. It's a pleasure and honor to be here. I will try to go through my talk, 45 minutes or so, and then would like it if you could bring up questions at the end of the talk, and we'll go from there. So these are my disclosures. No relevant disclosures here today, and no off-label drug use discussion here either. So for more than 30 years, clinicians have been investigating the use of advanced telecommunications and computer technologies to improve healthcare. And at the intersection of these efforts is telemedicine, which is the use of electronic information and communication technologies to provide and support healthcare when distance separates the participants. Electronic consultation, or e-consults, refers to asynchronous electronic communication between a consulting provider, who's typically a primary care provider, and a consulted specialist. So recommendations are formulated by medical record review and communicated via medical record documentation without direct contact between the specialist and the patient. And e-consults are distinct from other telemedicine visits. While the latter involves the use of information and digital technology also to diagnose and manage patients, telemedicine visits typically involve specialists interacting with and managing patients located in geographically remote areas directly to provide recommendations and follow-up. So telemedicine consultations also require lengthier visits, which typically last about 30 to 60 minutes compared to e-consults, which can be performed in 5 to 20 minutes. So the topic of my talk today will be e-consults, or interprofessional consultation without the presence of the patient. And the images here demonstrate changing trends in the practice of medicine over the years, with digital technologies being employed increasingly. So I will divide my talk into two parts. For the first part, I will provide an overview of the feasibility and utility of e-consults and where we stand in hematology specifically. And then in the second part, I will provide examples of some common clinical conundrums which we address via e-consults. So the demand for ambulatory subspecialty services has grown at rates that have overwhelmed many academic medical centers, resulting in impaired access and long wait times for patients. This drives down patient and provider satisfaction and leads to decreased quality of care. Based on a model initially developed and piloted at the University of California, San Francisco, the American Association of Medical Colleges launched Project CORE, which was coordinating optimal referral experiences in 2014 to help academic medical centers improve referral experiences both for clinicians and for patients. So through Project CORE, the AAMC has partnered with more than 40 ambulatory medical centers, children's hospitals, and healthcare organizations to successfully implement e-consults with tools built into the electronic medical record. Through this innovative model, core AMCs, and ours being one of them as well, are improving efficiency and effectiveness at the interface between primary care and specialty care, thereby improving quality of care and access in a patient-centered way. So making the trip to visit a specialist can come with a host of challenges for patients. The time and effort by the patient just to come in to see the specialist is not trivial, from taking time off from work to finding adequate parking at the medical center. And that's particularly important for patients with limited mobility or with other barriers to accessing care, like the geriatric population. So in addition, there are definitely providers who are paying out of pocket for their patients, almost always start with e-consults instead of referrals, just because it's more cost effective if the patient doesn't need to see the specialist in person. So with these in mind, specialists may choose to provide face-to-face care or provide e-consults and continue to have primary physicians or primary care providers manage care based on complexity of the patient's condition and or the patient's goals of care. So you can see the e-consult model shown here with a primary care provider placing an e-consult to a specialty provider, in this case to a hematologist, who can then provide a one-time answer or can co-manage on an ongoing basis or have the patient be referred to specialty or hematology clinic to be seen in person or as a face-to-face telemedicine visit. So e-consults may improve timeliness of care, may save costs, prevent unnecessary visits, and address the shortage of specialists. E-consult was initially implemented in radiology and pathology, but it's now in broader use in many, including internal medicine subspecialties. Unfortunately, access to classical hematology expertise is limited because of an imbalance between a decreasing pool of these subspecialty providers and an increasing number of patients with hematologic disorders. And this imbalance continues to grow. And in response, e-consultation is expanding to optimize access to hematologic subspecialty care, providing a triage mechanism to reserve longer face-to-face visits for patients with more complex conditions. So why are e-consults better than curbside consults? Curbside consults, as we know, are often inconvenient for one provider or the other. They have limited information that's typically provided to the specialist. There's no EMR documentation of the dialogue or plan, and there's no clear incentive for clinical time and effort by the specialist in providing this guidance. So what is the data for e-consult feasibility and utility in hematology? The diagnostic accuracy of electronic review of blood and bone marrow samples had previously been reported, but there was no published data regarding effectiveness of hematology e-consults until this paper in 2016, a report from the VA at Connecticut. So the Veterans Affairs Connecticut healthcare system initiated hematology e-consults in 2011 as part of a national initiative to improve access to care. And time to completion of these consults was typically about 30 minutes versus 30 to 60 minutes for in-person. 30 to 60 minutes for in-person. But it was also accompanied by an increase in the total number of consults received, unfortunately. So even though there was an 18% decrease in face-to-face consults and the overall population was a constant, there was an increase in the total number of e-consults received. So the proportion decreased, but the total numbers increased, raising the concern that the ease of e-consultation may increase consults that may not be appropriate or may not contribute to patient care. So this was certainly something that came up from the study. Of course, they did a survey and found that 65% of PCPs who referred patients preferred e-consults, and 100% of them were satisfied or very satisfied with the responses. Another successful e-consult service that was developed and published by Pai and team from the Kaiser Permanente system here, of the 906 total consults that were evaluated, 63% were handled with advice given electronically. And most commonly triage diagnoses then for in-person appointments after the e-consults were conditions like thrombocytosis or leukopenia or thrombocytopenia in 50 to 60% of patients, typically for more of an in-depth examination or for a diagnostic bone marrow biopsy. And importantly, of the consultation requests, 90% were addressed within 24 hours. Interestingly, also, they note that some of the ordering panels they developed for lab workup of common disorders and templates for FAQs to address primary provider questions are shown here. You can see examples of anemia workup, which includes creatinine, TSH, an SPEP, ferritin, iron labs, B12, and so forth. As well as an MGUS follow-up panel, which includes SPEP, kappa lambda ratios, calcium, CBC, creatinine, and so forth, as well as common reasons that this group identified for e-consults, anemia being the top reason, abnormal SPEP being another one, and so forth. So where do we, again, how would this work for fee-for-service models, which is similar to what we have here, as opposed to the VA or the Kaiser Permanente? And then how can you optimize for appropriateness of e-consults? Because this seemed to be raised as a concern for why there was an increase in the total number. And it didn't seem to decrease the total number of face-to-face visits at these specialty clinics. So this was a recent letter issued by the CMS, Center for Medicare and Medicaid Services, in January of 2023, so just 2 months ago, which superseded their earlier ruling clarifying that Medicaid and CHIP coverage and payment for interprofessional consultation is permissible even when the beneficiary is not present, as long as the consultation is for the direct benefit of the beneficiary. Definitely recognizing an increasing need for e-consultation services, among others. And you can see that I have highlighted some of the relevant parts of the letter here. With respect to reimbursements as well, this fee-for-service program, which was initiated at UCSF, the specialist receives a payment of 0.5 RVUs, and that's what I have highlighted here, RVU credit towards their annual productivity measures. And if the patient, and the PCP also receives 0.5 RVUs. And if the patient has a specialist visit within 30 days of the e-consult completion, the specialist does not receive this fee. And there's no co-payment required from the patient. So similarly, the AAMC also offers guidance for how FTE or CME fund contributions can be other ways to compensate specialists for e-consults, as shown here, over and above RVUs. And that was data from the University of Washington. So to answer the second question regarding the lack of decrease in face-to-face or total clinic encounters, here are summary data from the US e-consultation studies published in Hematology so far. You can see the average time to complete these consults was about 15 minutes. Our center's data is also included here. And face-to-face conversion rates ranged from 4 or 5% all the way up to 17%. Overall, face-to-face or total volumes did increase, suggesting perhaps that e-consults are either a combination of curbsides and face-to-faces as they stand, or that e-consults anyway end up being referred for face-to-face consults eventually. And it appears that it may be more of the former. That is, there are more in place of curbside consults, which are largely undocumented. So this was the University of Colorado e-consult service survey that asked their primary care physicians or providers what they would do in the absence of an e-consult service. And 76% of them responded that they would have informally consulted specialists if e-consults were not available. A similar survey at the University of Washington here, shown on the left, shows that physicians or primary care providers would have mainly ordered a standard referral had they not had the option of placing e-consults. And as this was similar for the University of Iowa as well, suggesting that maybe it is a combination of curbsides and face-to-face encounter referrals. So this is data again from the UCSF e-consult service. Most of the time when e-consults were placed, specialists, including hematologists, not only provided diagnosis and monitoring, as you can see in black lines here, diagnosis and monitoring, or diagnosis and treatment, or all three, diagnosis, treatment, and monitoring, even though most of the time the primary care providers mostly ask questions about one particular aspect. They either ask questions in gray, as you can see here, about diagnosis, or treatment or monitoring. The responses, though, happen to be a combination of all of these, providing more information than would was asked for. So again, suggesting that there was potential utility in these e-consults. In addition, you can see on the chart here on the right that lab tests and imaging were recommended by the specialist were ordered by the primary care provider 78 to 87% of the time. New medications or changes to medications were carried out as suggested 64 to 73% of the time, again suggesting utility of the service overall. And perhaps raising the question here about whether we should be using different metrics besides a reduction in face-to-face visits to evaluate the success of these e-consult programs. So to answer again the second question here in terms of appropriateness of e-consults, it is good to educate referring providers on what should constitute an appropriate e-consult. And this study from the Brigham and Women's evaluated situations that might be inappropriate. So you can potentially set up best practice alerts that can be one way to inform referring providers in real time regarding what might or might not constitute good use of their time as well as the specialist time. So for instance, anticoagulation duration in first-time provoked DVT. First-time provoked DVT is typically treated for 3 to 6 months, and then it can be discontinued. Again, this was a point of care resource test where the e-consult question can be easily answered by referencing clinical guidelines, which can potentially be performed by the primary care provider. Or if they have logistics questions, where can I send a patient to have a bone marrow biopsy at our hospital? This can be obtained directly by calling the lab or hematology admin offices, for instance. Or urgency, patient with an ITP flare with platelet counts of less than 2,000 per microliter. Again, the patient deserves immediate attention with a specialist via a face-to-face encounter, or certainly an ER referral here. And complexity. So if you referred a patient who was 43 years old with AML who had recently had a transplant or had a transplant 4 years ago and now presents with bicytopenias, leukopenia, thrombocytopenia, fatigue. Again, I think that the patient complexity here warrants a direct face-to-face consultation. So this study looked at how frequently consults that were placed were appropriate. And 2/3 of the time, they were actually appropriate consults in this overall evaluation, suggesting that maybe people are already on to understanding when to refer and when not to. Of course, there is 1/3 of the time when consults were considered by two inter-rater, without much inter-rater variability by two independent specialists, that e-consults, about 1/3 of them were potentially inappropriate. So at the UW, the referral optimization project that I mentioned earlier help streamline these pre-consultation guidances, including having the referring provider develop a clear question, ensuring that key diagnostic data are made available at the time of consultation with the specialist, but also from a specialist responsibility standpoint, a clear co-management plan is drafted and all as part of a structured, comprehensive template. So a key question, key labs, and then the specialist is responsible for drafting a clear plan. And all of this needs to be done with a 3 business day turnaround time by the specialist. So when you place a referral to hematology, you typically choose the specialty on Epic, and then you choose and fill out condition-specific or the unspecified template, and you sign the order. You then receive within 3 business days. In most instances, you receive results via an in-basket message. Some of these parameters, as I mentioned, are already linked to the diagnosis that you choose, and the pre-consultation prompts are in place for you to ensure that it is actually something the specialist can help you with and that it is good use of your time and theirs. And I can show you an example in the next few slides of these prompts and guidances. So not really a geriatric patient here, but to give you an idea, this is a 39-year-old female with chronic leukocytosis. A CBC was ordered and data were extracted into the note from the EMR for review directly. And the template then specifies labs and history pieces that were unanswered or missing. So missing or not missing. Here, For instance, pathology review of the peripheral smear was not available, but we do have history information that the patient is not a smoker. So then the next step is for the specialist to draft a detailed response based on a thorough record review. And this includes restatement of the question. So you identify the specific question that the PCP wanted you to address and your impression of the patient's condition. So you can dig through medical records and find additional information, as I will show you next. Then make your clinical recommendation and provide rationale for your recommendation, either via existing evidence or in the absence of evidence, how you made your recommendation. And finally, finish with a contingency plan. And this is important because you want to help them understand what is appropriate for a reconsult or a referral or other possible testing or recommendations with options. And then you specify how much time you spent reviewing these records and the information. So interestingly, I review her records and her BMI stands out as being 45 here. And then I ask for a peripheral smear to review and rule out some of the common malignant conditions associated with a chronic leukocytosis. Otherwise, it seems like the most likely cause for a stable, persistent leukocytosis in a young adult would be reactive. And in this case, it was obesity. And I finish with a contingency plan here, stating or clarifying to reach back out if any of the test results returned abnormal or if other WBC or differential abnormalities began to appear with future surveillance. So again, this exemplifies one of our templates. Another example here is of a 75-year-old female with thrombocytopenia. The question is whether she can proceed with breast implant surgery with platelets consistently greater than 100 per 10 per 9 per liter. And this is one interesting side note here, that the patient had rhabdomyosarcoma in 2021. And I review the results in the note for information that is missing. You can see it gives you a list of labs that are needed to be performed along with the e-consult placement. And it's also important, by the way, when placing a consult, to let the patient know to possibly expect a call from specialty clinic in case a referral is indicated. So on digging through the records further, I identify mild, isolated, persistent thrombocytopenia, which has always been in the 100 to 130K range. And she has had excision and radiation for the rhabdomyosarcoma. Now, of course, chemo or radiation can cause bone marrow suppression and MDS in the longer run, as you know, but looks like it was involved field radiation in very low doses and quite recent, so unlikely to have an impact. So we also rule out conditions like hepatitis B, C, TSH for thyroid issues, ANA if relevant, and H. pylori, which happen to be available on record review. So I include all of this information here. Then I make recommendations to order some of the missing labs. So pathology review of smear, HIV testing was not available on record review, abdominal ultrasound to rule out splenomegaly, fibrinogen to rule out a low-grade DIC in this case, and then suggest monitoring with CBCs at regular intervals. Now, the rationale again is that this is mild, isolated, persistent thrombocytopenia that does not require diagnostic workup like a bone marrow biopsy or aggressive management outside of a clinical trial setting where maybe a bone marrow biopsy would be performed. But in most individuals, survival is not greatly impacted, even ones who are older than 60 years of age. And there is data for this from this Dutch study that I quote here. Most importantly, say that the patient is cleared for breast implantation surgery from a heme standpoint, as long as there were no prior bleeding issues. And then, of course, suggest a contingency plan for what to do when any of the results return abnormal, or if the thrombocytopenia were to worsen, or if bleeding were to occur. So, of course, we don't always have the PCP monitor the patient. This is a thrombocytopenia case, also mild, but you can see with a clear downward trend, and with alcohol use chronically, drugs that can cause platelet dysfunction or thrombocytopenia, and hepatitis B, C, DIC, and others were not ruled out. So I say, let's start with abstaining from alcohol. And then also, however, place a non-urgent hematology consult as there is a clear downward trend in platelets to make the consult more urgent if the platelet drops below 50,000 and or bleeding or other significant cytopenias were to develop. So this is a condition where I would refer or self-refer in this case because I've reviewed the chart and would like to see the patient and evaluate more closely, perhaps even with a bone marrow biopsy if indicated. So this, the next part of the talk will be the common clinical conundrums that we come across. And these are referral patterns for hematology consults, a summary of what we see here. I have already shown you some data on thrombocytopenia and leukocytosis management. And I will talk about some of these other conditions, anemia, MGUS, polycythemia, hemochromatosis workup, and so forth. So with thrombocytopenia, and I reviewed the case with you earlier, but in the important differentials are outlined in this attached paper by the American Association of Family Physicians. In the elderly, special attention is to be paid to bone marrow suppression or chronic alcohol use, MDS, nutritional deficiencies like B12 and folate, or drug-induced thrombocytopenia, or liver disease. Again, the table on the left here shows you a list of drugs that are commonly implicated in thrombocytopenia, and these include cardiac medications, alcohol, antibiotics, heparin, diuretics, antiepileptics, NSAIDs, sulfa drugs, and so forth. And the algorithm on the right here shows you the general management schema for thrombocytopenia as we did in our previous example that I showed you. So you look first for a peripheral smear and make sure that there's no associated anemia, as well as their CBC results to make sure there's no associated cytopenias, anemia, leukopenia, leukocytosis, and so forth. Probably less relevant for the geriatric population, but also helpful to obtain a childhood history or a family history, and then perform a peripheral smear, make sure there's no bleeding, petechiae, or bruising, and if they're asymptomatic, also get an EDTA or a citrated tube of in which you can get CBC to make sure this is not platelet clumping mediated or pseudothrombocytopenia. Once you have confirmed that the platelet counts are real, you can then triage this patient based on their platelet counts. If the platelet counts are consistently less than 50 times 10 to the 9 per liter, it's best to consider a hematology referral, potentially for a bone marrow biopsy or additional treatment. If it's between 50 and 100, you can repeat counts. And if it continues to trend downwards, it's important to make a referral like that patient I just showed you, the second case. And then if it's consistently between 100 and 150, like the first case, you can continue to just monitor. Initially, maybe repeat every 2 to 4 weeks, but then after that, you can space it out and just keep an eye on them. Leukocytosis was the other case that I demonstrated earlier. Again, this is just to refresh your memory on WBC maturation. You can see the life cycle of leukocytes here and the differentiation not only into neutrophils, but also into basophils, eosinophils, monocytes, and lymphocytes. And this table here on the right shows you the distribution or the normal percentage of the total leukocyte count that the neutrophils, lymphocytes, monocytes, eosinophils, and basophils make up. So it's good to review these charts intermittently to see if the patient has a differential that might be standing out. Most of the time, the medical record itself does this for you and highlights these conditions. So leukocytosis, again, non-malignant causes of neutrophilia. This is something that we looked at earlier, but obesity, for instance, race, age can affect neutrophilia, or pregnancy. Infection is a common cause. Reactive neutrophilia like stress or exercise, smoking, and so forth. Chronic inflammation because of rheumatologic disease, inflammatory bowel disease, vasculitis, hepatitis can affect or increase neutrophil counts. Could be medication-induced. Corticosteroids are a commonly implicated agent. Patients could also be on lithium and other agents. Bone marrow stimulation using GCSF and other factors. Splenectomy, history of splenectomy can cause leukocytosis, for instance. And then congenital causes, which are probably less relevant in the geriatric population. What is more relevant, though, is evaluating in detail, which obviously one cannot do as well on an e-consult, which is why we rely so heavily on the primary care provider, is evaluating for findings suggestive of hematologic malignancies. So even though we issue a blanket statement in our note saying, make sure that the patient doesn't have bruising or bleeding or fatigue or immunosuppression, B symptoms, lymphadenopathy, splenomegaly, it's important to think through each of these and make sure that the patient does or does not have these and whether or not they are explained or unexplained, because that can totally drive how you manage these consults or co-manage these consults with the specialty physician. Same thing with laboratory abnormalities, especially if you identify something unusual on the smear or additional cytopenias. It's always good to circle back to the consulting physician and ask for more information about what it could mean. WBC subtypes could mean specific conditions. Basophils, eosinophils, or basophils monocytes can be increased, for instance, in CMML or CML. Eosinophils may also be increased in hematologic malignancies, but most of the time it's an allergic reaction or drugs hypersensitivity or parasitic infections, for instance. Monocytes can be increased in autoimmune disease and in splenectomy in addition to infections. And of course, the differentials for neutropenia is something that I covered here. With respect to leukocytosis management, again, this is an algorithm with reference provided here. You repeat counts and you obtain a peripheral smear. And if leukocytosis is confirmed, the first thing to do is to rule out a malignancy. And this can mainly be done through an HNP with evaluating for unexpected weight loss, night sweats, fevers, and so forth, and B symptoms, as I mentioned. And if these are present, immediately refer the patient for a bone marrow biopsy. If they are absent, then evaluate for type of leukocytosis. Is it neutropenia? Then you rule out infection, inflammation. Is it lymphocytosis, monocytosis? Then think about autoimmune conditions or splenectomies. And eosinophilia, think about allergies or drug reactions. Basophilia could also mean malignancy. So I would go back and look for any causes of malignancy. And we, of course, have a panel of tests to order for leukocytosis, almost as a way to ensure that we're not missing any of the serious treatable hematologic malignancies. Neutropenia, on the other hand, or low neutrophil counts, one also evaluates for history of infections, prior neutropenia and other cytopenias, as well as medications. Diet and alcohol can affect it. Examination for liver disease or acute chronic infection is important, or a rheumatologic disorder. SLE, for instance, can cause neutropenia, whether it's because of an enlarged spleen or because of autoimmune neutropenia in those cases. So assessment for neutrophil morphology is helpful with a peripheral smear. And then review meds, because antipsychotics or antiepileptics can cause neutropenia. NSAIDs, anti-thyroid medications, have been implicated in a potentially life-threatening condition called agranulocytosis, with absolute neutrophil counts being less than 500 sometimes. So important to definitely look at the meds tab and also rule out viral hepatitis, HIV, EBV if relevant, and rule out malignancy, as I mentioned earlier. Nutritional deficiencies can be a big one. And finally, this condition called benign ethnic neutropenia is not associated with increased risk for infections, and recently the name has been changed to be called Duffy null associated phenotype, which is common in individuals of African descent or in some Jewish populations, West Indians, Yemenites, Greeks, and Arabs. And if a bone marrow biopsy is normal, that is, sometimes you do perform a bone marrow biopsy if neutropenia is low, persistent, or progressive. If this bone marrow biopsy is normal, then you consider other conditions like cyclic neutropenia, autoimmune neutropenia, especially if anti-neutrophil antibodies are positive, although it's not a very sensitive test or a specific test, or chronic idiopathic neutropenia. So moving on here to anemia in adults and elderly, a low serum ferritin in a patient with normocytic or microcytic anemia. I show you two charts here for normocytic, microcytic anemia, as well as macrocytic, where the MCV is greater than 100 FL. Now, a low serum ferritin level in a patient with normocytic or microcytic anemia is typically associated with iron deficiency anemia. In older patients with suspected iron deficiency, it's important to perform an endoscopy to evaluate for GI malignancy. And patients with an elevated serum ferritin level or a macrocytic anemia should be evaluated for underlying conditions like a B12 folate deficiency, myelodysplastic syndrome, MDS, and so forth. MDS malignancy or nutritional deficiencies. And treatment is directed mostly at the underlying cause, and symptomatic patients with serum hemoglobins of less than 8 grams per DL may require blood transfusions, as you know. Patients with suspected iron deficiency anemia should be given a trial typically of oral iron and lower dose formulations. And there is newer data to support this. As you know, lower dose formulations as well as every other day dosing may be as effective and have a lower risk of adverse events. Normalization of hemoglobin typically occurs about 8 weeks after treatment in most patients. And parental iron is reserved for patients who have not responded to or cannot tolerate oral iron therapy. And again, people use different combinations of these tests. But in addition to a low serum ferritin, I always look at the transferrin saturation. And if the transferrin saturation is less than, say, 15% and trending downwards, I also treat them as if they were iron deficient and provide oral and/or IV iron. Moving on here to superficial vein thrombosis, superficial venous thrombosis and anticoagulation management. Again, a question that arises commonly as an e-consult. You can see based on this algorithm, again, that if there is a concomitant DVT in addition to an SVT, you follow DVT anticoagulation guidelines, which I will show you next. But if a superficial venous thrombosis is present by ultrasound and is less than 3 centimeters from the saphenofemoral junction, so proximal, high up in the thigh, you would still anticoagulate as if you would anticoagulate a DVT. Now, if it's greater than 3 centimeters and greater than 5 from the SFJ and is greater than 5 centimeters in length, then you could consider, this is a grade 2B recommendation, but you could consider prophylaxis instead of therapeutic anticoagulation with either fondaparinux or low molecular weight heparin for 45 days. And then you can always re-image or evaluate clinically for symptoms. If they don't have any of this and the SVT is more distal or is small, you really don't need to anticoagulate these patients and just consider symptomatic treatment, for instance, with NSAIDs or other local measures. So I mentioned VTE management, and these are ASH or American Society of Hematology VTE guidelines that were published in 2020, which I refer back to quite a bit for guidance on how to manage several of the consults that I receive. One important point to make here is that hypercoagulable workup is almost never indicated in most, if not all, adult or elderly, because it would not change treatment guidelines that I'm going to discuss here. So the main takeaway points from the 2020 ASH VTE guidelines are that unprovoked DVT or VTE should typically be treated indefinitely. We know, most of us are aware of that, as the recurrence rate is as high as 30% over a 5-year course. Now, typically, people have used prognostic scoring systems in the past to determine which of the unprovoked DVT-PEs should be treated indefinitely. And ASH recommends against using these prognostic scoring systems in most instances and just treat indefinitely when possible. Now, if VTE is provoked also by a chronic risk factor like IBD or autoimmune disease, the recommendation does say you treat indefinitely, but they include the caveat that these may not apply to patients with high bleeding risk. They recommend against using aspirin as secondary prevention. So if you do want secondary prevention, you want to be using anticoagulation and not aspirin. For secondary VTE prevention, you could consider DOAX-DO at prophylactic doses or lower dose DOAX compared to standard dose DOAX. And there is some data for this suggesting that in the follow-up period, after you finish the acute DVT management, you could lower the dose of DOAX with an increased risk or a small increased risk of non-fatal PE occurring in individuals who got lower dose DOAC compared to those who got higher dose DOAC or standard dose DOAC. So especially in patients who are at bleeding risk, you could consider lowering the dose of the DOAC after they finish their initial treatment phase. Now, for recurrent VTEs, we all know that if there are transient risk factors, they just had surgery and they had a clot, and then they had another surgery and had a clot, you only provide episodic anticoagulation. For everything else, if you had a transient risk factor once and then you had chronic underlying conditions, or you had an unprovoked VTE in the past, the answer is always indefinite anticoagulation, with, of course, periodic risk-benefit analysis and bleeding risk assessment, especially in the geriatric population. Questions regarding MGUS, myeloma workup, and these arise in the setting of a neuropathy workup or such, and is based on SPEP results, for instance, that might say the protein electrophoresis demonstrates a significant increase in the gamma region, likely representing a polyclonal expansion. Now, in these instances, it's important to recognize that a polyclonal gammopathy, as shown in the SPEP pattern here on the rightmost corner, is not the same as a monoclonal spike, which is what is shown in the middle here, with a clear peak in the gamma globulin fraction. This is what is noted in MGUS or smoldering myeloma or frank myeloma and in certain other conditions. This is your normal SPEP pattern. Monoclonal spikes look like this, and polyclonal gammopathy or hypergammaglobulinemia looks something like this. In addition, so the latter the polyclonal gammopathy doesn't constitute an MGUS. In addition, a serum immunofixation quantifies the monoclonal protein and characterizes it as arising from a particular clone of plasma cells, typically with a heavy chain and a light chain specificity. So the report would read the quantity, which here is 0.3 grams per DL, and it would tell you the type. In this case, it's an IgG kappa monoclonal protein, which can be followed over time. So again, the figure here illustrates a polyclonal antibody base that normal plasma cells generate. And if there are abnormal plasma cells like in MGUS or multiple myeloma, they generate a clonal or a monoclonal set of antibodies which have a fixed light chain and a heavy chain, which can be captured on immune electrophoresis. So these tables here are from a recent review that provide criteria to make a diagnosis of IgG or IgM or light chain only MGUS. And it also provides clinical or lab findings that might herald malignant progression in the table here on the right, like anemia or hypercalcemia, unexplained creatinine elevation, and so forth, or if the M protein or the FLC ratios are significantly elevated above the cutoffs here, is something that you want to be watching out for in any of these three conditions. The other typical questions we receive are, when should we do imaging or bone marrow biopsy on patients, or how to do a follow-up? So suggested algorithm here for a bone marrow biopsy and skeletal imaging, you can see in patients with MGUS with standard risk factors who do not have those complicating factors that I showed you on the previous table with clinical and lab criteria, if low risk and uncomplicated by those criteria, clinical and lab, we can typically defer a bone marrow biopsy or a skeletal survey in IgG, IgM, or in free light chain MGUS. Typically, follow-up, in terms of follow-up, a 6-monthly follow-up or a 4 to 6 monthly follow-up can be recommended if there is an intermediate or a high-risk MGUS, or if the chains are increasing and so forth. If it's low-risk MGUS, typically no additional follow-up. And these guidelines have changed over the years. You know, in the past, they would say, just do 4 to 6 monthly MGUS labs on all these patients. But increasingly, low-risk MGUS progression is so low that most people these days don't even recommend routine follow-up, except, of course, it's important to very carefully assess for intermediate or high risk. If you're worried about it progressing for whatever reason, it's important to get CBC, calcium, creatinine, SPEP, and free light chains again. So you can then risk stratify and then work up for a lymphoplasmacytic malignancy and manage accordingly if you identify these. So our group here evaluated MGUS diagnoses and follow-ups performed via e-consults at the VA. And the median time to, so you can see a whole different risk categories of MGUS or risk distribution was across the board for the various MGUS categories who were followed via these e-consults. And MGUS diagnoses were more likely to use multiple encounters. You can see for follow-up on the right here compared to other e-consults, where most of them were first one-time only consults. You can see that these were one-time consults, but they also had a lot of multiple e-consults or follow-ups. So in this study, there were 6 documented progression events over 44 months, and the average progression rate was about 1% per year, which is consistent with the data we know from the literature. And the authors concluded that e-consult is a helpful mechanism for evaluation of MGUS and reduces the need for outpatient appointments. However, timely risk stratification and persistent surveillance are critical to for e-consults to work well. And again, a huge responsibility on the part of the geriatrician or the primary care provider, and they should be compensated appropriately for having to identify these intermittently and thinking about them. 2 more cases, finally. Polycythemia vera typically rules out, this is how polycythemia vera is identified. These are WHO criteria from 2016, elevated hematocrit, very low serum EPO level, or JAK2 mutations. If any of these are present and or a subnormal erythropoietin is present, then you can make a diagnosis of polycythemia vera. Now, if that is excluded for whatever reason with any of these tests, think about other conditions that cause erythrocytosis or increase hematocrit here, including cardiopulmonary disease, which can cause reactive elevations in erythropoietin levels. Sleep apnea is a common one. Medications such as testosterone or EPO itself can increase it. Smoking, renal artery stenosis, rarely EPO-producing tumors, and other MPNs. So for instance, when we order JAK2, we order something called JAK2 reflex testing, which also includes ET and MF, CMIPL and CALR mutations. So you rule those out as well. And then you also check for CML-related mutations, which can be helpful ruling out all the most serious conditions. But I always have people perform a sleep study because that's one of the most common conditions for secondary erythrocytosis. Hyperferitinemia is a reason for e-consultation or abnormal iron studies. So really, you start by considering iron-loading anemias and hereditary hemochromatosis, all shown on the left here, when serum ferritins are elevated only and only if the transferrin saturation is also elevated, so greater than 45% persistently. If your blood counts are normal and the ferritin and the T-sats are both elevated, which can happen in Caucasians, you may consider sending for HFE gene testing. Alternately, you rule out other metabolic causes for iron elevation, such as infection, inflammation, chronic alcohol use, metabolic syndrome, hepatic malignancy. And if the ferritin is still greater than 1,000 persistently, this is a big number. Consider assessment of liver iron stores via a T2 MRI before performing additional phlebotomies or such. And otherwise, it's important to manage the underlying condition. We get a whole host of referrals from a variety of different services for metabolic syndrome, which then gets tested for HFE genotype. And I can tell you, C282Y homozygous is what is considered HFE. Everything else could have a metabolic syndrome component and is not considered HH and should be worked up and treated as if they have metabolic syndrome or other inflammatory, chronic infectious inflammatory conditions. So I hope I've provided you with an overview of hematology e-consults for geriatric patients, their feasibility and utility. We discussed reimbursement, successes and challenges in fee-for-service and other models. We also evaluated ways to streamline referrals by asking that referring providers develop key questions and complete prelim labs before the consult, and the use of structured templates for responses, which are condition specific, is important by the specialist providers. And so we covered algorithms for the diagnosis and some management of common hematology consults in the geriatric population here at the UW, including anemia, thrombocytopenia, leukocytosis, leukopenia, MGUS, anticoagulation management, polycythemia, and elevated ferritin workups. So for more than 30 years, I leave you with this slide here. clinicians, as I mentioned, have been investigating the use of computers and telecommunications to improve healthcare. And telemedicine stands at the intersection of many of these efforts. Instead of saying, for instance, don't confuse your Google search with my advanced medical degree, I think these days it behooves us as physicians and as specialists to partner, or providers and as specialists to partner with these technologies. I recently heard a physician, introduce this conversation with a very well-informed patient and family, where he says a well-informed patient or family may be a helpful thing for physicians, with helping understand and make decisions, for instance, about treatments or side effects, and about what to expect, and about hopes and expectations. That is much easier overall. And in many ways, that could help build a therapeutic alliance from the get-go. This is especially true in light of the fact that the popularity of artificial intelligence continues to grow at a rapid pace. In the month since its launch, the chatbot ChatGPT became the fastest growing app in history, with 100 million users in January. And this is an open AI has introduced a $20 a month subscription fee that offers several benefits, including covering medical questions. And it was even able to pass the USMLE recently and made clinically valid hypotheses when making a diagnosis. So this was, again, I think we all need to, the future is here, and we all need to evolve with the times. This, for instance, which I just included here, is fresh off the press. MDS can be difficult to diagnose, as many of you know, with cytogenetic, molecular, and phenotypic pleomorphisms. And there was a lot of inter-rater variability when people physically assessed these bone marrows and flow data. The software here shows developed between Harvard and a French group, eliminated these variations and made diagnosis very accurately. And this model allows for diagnosis of both high-grade and low-grade MDS with 92% sensitivity and 93% specificity, decreasing misclassification in more than 50% of patients. So with that, I will conclude my talk, and I am happy to take questions. And this is the QR code that I was asked to display here.
Thank you so much. Thank you so much. I think there were a couple questions that came in as you were speaking. One of our fellows, Sophia Jaramillo, was wondering about, since the physician is not seeing the patient, but making formal recommendations for their care when it comes to legal responsibility, how the physician-patient relationship works in e-consults.
Yeah, no, I think that's a great question. And there's a lot of, it's an important area for improvement and research. I would say, there are times when I write these e-consults where I cringe, right? Because a lot of it is templated. I say, make sure the patient doesn't have B symptoms, make sure there's no splenomegaly, make sure no fever, those sorts of blanket statements. I feel like that is why it's extremely important for there to be a co-management plan with the geriatrician or the primary care provider to say, a lot of the physical assessment and the actual physical exam rests on you, which is why I think it's good to demonstrate that the RVUs are also shared. The responsibility is shared. The reimbursements should be shared. I don't know if they are, but they should be shared, because there's so much that a primary care provider has to go back and do with the patient after they have read the note. And so I think that that's a piece we shouldn't take for granted from an ethical standpoint. And there are medical legal issues, as you mentioned appropriately. So again, I think this is a start, but certainly lots of room for research and improvement in these areas.
A couple, a quick question of if you would be willing to share your slides with us. And if you would, I'm sure Diane would be happy to distribute them to folks. And if not, that's okay too.
Absolutely. Yeah.
Fantastic. Thank you so much. And you've converted one of the nearby geriatrics fellows to e-consult. So
I am Thank you for that. I know, we all are on the fence sometimes. I myself, when I started doing this, I said, this is just so inadequate. I really do want to see these patients, for instance, right? But I think over the times, you have to be cognizant of the fact that I can only see, or we can all only see a finite number of patients a day, and when there is such a crunch, I think, as much as we want to say, I want it to be perfect, I think that, we have to start thinking of creative ways to make these electronic platforms work to our advantage and to the patient's advantage.
And I know a lot of us care for patients, whether it's patients who are homebound or nearly homebound,
Right.
or in the post-acute care service, we have a lot of folks from who are rounding in nursing homes where being physically present for a consult is so hard. So I found e-consults really helpful to be able to, within the constraints of what we can do, be able to provide the best care to my patients. And Dr. Phelan is wondering if there's data on patient satisfaction with e-consults.
Yeah, and there are. I didn't show you that data, or maybe I did. There was one slide there that looked both at provider satisfaction and at patient satisfaction. And of course, they asked questions like, would you rather have come in for a visit, for instance, right? Especially in the Pacific Northwest. I moved here a year ago from the East Coast, where my patients didn't have to travel more than 40 miles. I mean, here we're talking 300-400 miles sometimes. And, I have become much more acclimatized to saying, yeah, I mean, telemedicine visits, of course, but also understand why functions like these are going to become increasingly a necessity with geographical distances.
I think we have time for one last question, and Dr. Hansen has her hand up.
Oh yeah, hey, good morning. A quick comment and quick question. Thank you so much for this. I was actually just talking about this last night with my husband. Our Memory Brain Wellness Center was featured at this big giant clinic meeting for being a good clinic example of poor access. Because we're like a year wait and people can't get in. So I think we were just the one featured. We're not like the only one. Anyway, everyone has dementia and no one can get in. So could we utilize something like this? So thank you for going over the first few slides. Quick question, do you think something like an e-consult for heme, or some of these kind of lab specific consults like heme or renal, would be useful for like the research setting? I identify a lot of abnormalities. In fact, I diagnosed a case of ET. Maybe you saw her in my metformin study. And, I'm just wondering about what, and maybe a study would pay for those e-consults. Like how many of these folks need to come in and how many can we, or do I just turf it to their primary? But I'm just thinking like an e-consult along the way might be a nice way to protect everyone when they get these labs that are abnormal.
Within a research study, right?
Right.
Absolutely.
Yeah, they always get these huge set of labs, and they get
Yes.
a basic exam from an MD.
Right. Right. And I think,
thrombocytopenia, I get so many.
Exactly. No, absolutely. In fact, I think with a lot of these research studies, right, there's inbuilt language there to say, if you find something abnormal, even though it's not directly relevant to your research, I think for instance, with genetic counseling or something, right? I think there is language in there that says it's important to make a referral. But I agree with you. There's one or two distinct abnormalities that can be posed as finite questions. I mean, those would all be absolutely appropriate for e-consults in patients who are otherwise stable and can wait 3 days for an answer, for instance, right? And any other such situation. And one of the reasons I showed these to address your former comment, one of the reasons I wanted to include those initial slides is because I know geriatrics also is interested in being consulted for e-consults or participating in e-consults from a from a consulting provider standpoint, right? And so I think it's feasible. I think there is utility with any service being the consulting provider for e-consults. And increasingly, patients And that's what I was trying to allude to in the last slide. They come in doing a lot of the research. So if you told them, track your fevers for me, or make sure you don't feel lumps or bumps, they will do it, for you. So
especially in the research setting. I mean,
Right.
these people come in with like way more records than I need, which is great.
Yeah, absolutely.
Thank you so much. We're right at 9:01, so we'll have to wrap up, but this is a great conversation, and I really appreciate you presenting information that's so relevant to us, not only because we are looking at and have started e-consults in geriatrics, at least in senior care clinic, but also utilize them quite a bit for our patients, and reviewing this is super helpful. So thank you so much for taking the time with us, and I'm sure you will hear from many of us in the future, but maybe on fewer cases because you taught us what to do. So thank you so much.
Thank you. I appreciate it. And thank you for the opportunity. Bye.
Have a great weekend, everyone.
You too. Bye.